Hello, everybody. Good evening. It's nice to meet you again in one of the virtual activity of IAVA CME regular courses. And today is one of important courses prepared and directed by Professor Ahmed Shawqi, Professor of Cardiology at Shams University. And it is very interesting. Because it concentrates on what happened in the emergency room. And I think every one of us is keen to know how to deal with the cardiovascular emergency situations. So I will leave Professor Shawqi now to tell you the objectives and program of tonight and tomorrow emergency room course. Professor Shawqi, تفضل.
Thank you Professor Ashraf, Professor Hazem, Professor عاطف.
بعد اذنكم بس عاطف بيحاول يخش وحياتك ايكم.
معانا
مساء الفل عليكم كلكم. اشرف مساء اشرف. حازم حبيبي حازم ازيك؟
اتفضل يا شوقي.
Thank you all. We're all physicians. We all had a round in the emergency room. We have to really know what to do when we see chest pain. We have to know what to do when we see ECG. Whether normal or abnormal. We should know what is the importance of correct diagnosis, thus correct management. And we will also have to know what we do with the most prevalent risk factor, hypertension. So over tonight and tomorrow after Friday prayers, we're going to take a depth look into some problems in the ER. For this course, it's the ER course. It's for all of us. Cardiologists, IMs, intensivists, all physicians should really have an insight into this. I have to thank the IAVA board, Professor Ashraf, Professor Atif, Professor Hazem, Professor Hani, everybody, and all the speakers. I have to thank ICOM. Really, thank you so much, Marianne, and the whole team from ICOM. And thank you so much, Novartis, for really giving us this opportunity for a non-promotional course. They have very graciously helped us and supported us. Over the next 2 days, tonight and tomorrow, we're going to take a deep look into cases and how to manage. And if, without further ado, I think Professor Atif or Professor can introduce the first speaker for today. Professor Atif, if you would like to.
Okay. Hello everyone. I'd like to introduce the first presentation. سامعين يا جماعة؟
سامعك دكتور.
تمام. Professor Tamer will start his presentation.
Okay, ready. Good evening to everyone, to IAVA board and to Dr. Ahmed Shawqi. Thank you very much for his great efforts in this course of chest pain in the ER. I will start with the differential diagnosis of chest pain in the ER. What is the diagnosis and what is the differential diagnosis of a chest pain case in ER? We should differentiate between life-threatening chest pain and non-life-threatening chest pain. Because life-threatening chest pain may be coming from mediastinum, as in mediastinitis and esophageal rupture, from the great vessels, as dissecting aneurysm, pulmonary embolism, from the heart, like myocardial infarction, angina or pericarditis, respiratory, pulmonary, as in pulmonary embolism and pulmonary infarction, pneumothorax, pneumonia, and pleuritis. This pain may be also non-life-threatening, coming from functional pain like anxiety and hyperventilation, spinal dysfunction with cervical or thoracic dysfunction, from the chest wall, trauma, pathological fractures or osteochondritis, from infection like herpes zoster, and from EGIT also like esophagitis and GERD, esophageal spasm, peptic ulcer, erophagy, gallbladder disease, and the pyloric colic. Here's the probability, first question, probability diagnosis. It may be simple as musculoskeletal chest pain or psychogenic, and it may be angina. So what is the serious disorders not to be missed? First is cardiovascular. cases of myocardial infarction, unstable angina, acute aortic dissection, pulmonary embolism, or infarction. Neoplasia can cause chest pain, like lung cancer, or tumors of spinal cord and meninges. And severe infections, like pneumonia and pleuritis, here the pain is pleurisy, mediastinitis, pericarditis, or pneumothorax can also cause a pain, which is important. What are the causes of chest pain? Vascular, there's primary cardiovascular and primary cardiovascular. In the cardiovascular pain, it may come with acute coronary syndrome, STEMI, non-STEMI, and stable angina. It may come with acute pericarditis, acute myocarditis, with severe hypertensive crisis, with stress cardiomyopathy, Takotsubo syndrome, with tachyarrhythmias, hypertrophic cardiomyopathy or aortic stenosis, with severe acute heart failure, acute aortic syndrome like dissection or hematoma, pulmonary embolism, pulmonary infarction, or cardiac contusion. It may be also primary but non-vascular, like esophageal, peptic ulcer, pneumonia, pulmonary embolism, osteochondritis, fracture, and other causes of chest pain, which is of non-cardiac source. In patient with the case, for example, acute pulmonary embolism, there's a score. The score which gives me the probability, presence of clinical signs and symptoms of DVT. Example, objectively measured like swelling or pain with palpation of deep leg veins, we give 3 score. Pulmonary embolism as likely or more likely than an alternative diagnosis with 3 points. Heart rate more than 100 beats per minute is 1.5 point. Immobilization as a bit risk except for bathroom access for at least 3 consecutive days or surgery in the past 4 weeks, 1.5. Previous objectively diagnosed DVT or pulmonary embolism, 1.5. Hemolysis, 1 point. Malignancy, 1 point. From this score, we can collect the points. If the points are less than 2 points, there is a low risk of pulmonary embolism, with probability of pulmonary embolism to be from 1 to 28%. If a score from 2 to 6 points, there is a moderate risk of pulmonary embolism, with probability from 28 to 40%. If the score is more than 6 points, there is high probability, which range from 38 to 91%. For initial talking, don't forget TDS 5B. The red flag pointers for acute chest pain. The T is thoracic back pain, and 2D, dizziness or syncope, and dyspnea. 1S is a sweating. Then 5B, pain in the arms, especially if left more than right and jaw. Palpitations, pain on inspiration, pallor, or past history for ischemia, diabetes, or hypertension. What are the questions commonly asked for a pain for chest pain patient? Where exactly do you get the pain? Does the pain travel anywhere? Can you give me a careful description of the pain? How long does it last? And could you do anything to relieve it? Is the pain brought on by exertion and relieved by rest? Do cold conditions bring it on? Do you have any other symptoms such as breathlessness, faintness, sweating, or back pain? Is the pain made worse by breathing or coughing, or by movement or pressing on that area? Is there any blood in sputum you bring up? Is your pain associated with what we eat and drink, or with a bitter taste in your mouth? Do you get the pain when stooping over and after lying in bed at night? Do antacids relieve your pain? Have you noticed a rash where you get the pain? And have you had a blow to your chest or an injury to your back? These are the common conditions related to chest pain, which is cardiac or non-cardiac. The history, you should ask for the site, for the onset, character, the severity of pain, duration, radiation, what are the aggravating factors, and what are the relieving factors, and what are the associated symptoms. According to the site of pain, is it retrosternal chest pain or peripheral? If retrosternal chest pain, it may be cardiac with angina, myocardial infarction, myocarditis, pericarditis, and mitral valve prolapse. Mediastinal, like tracheitis and malignancy. Aortic, like dissection or aneurysm. Esophageal, like esophagitis, esophageal spasm, Malur-Weiss syndrome, and maybe with an anxiety and emotion. If peripheral, we can think for lung and pleural, like pneumothorax or infarction. For malignancy, musculoskeletal chest pain, like cryptoma, muscle injury, osteoarthritis or osteochondritis. Breast disorders, neurologic, like herpes, and anxiety. What is the onset of chest pain? If sudden and retrosternal, you think for myocardial infarction, pneumothorax, or esophageal rupture. If peripheral, you think for pneumothorax or pulmonary embolism. Gradual pain on exertion, may think in angina. After vomiting, may think of esophageal source. Constant pain, think for pericarditis and musculoskeletal pain. Occurring when and what is the duration? If on exertion, think for cardiac chest pain. If on food intake, think for esophageal source. If the duration is than 20 minutes and typical ischemic, it may be angina. And if it persists for longer than 30 minutes, you think for myocardial infarction. What is the character and what is the severity of your pain? If constricting pain, we think for cardiac or esophageal spasm. If stabbing chest pain, think for pleural or musculoskeletal chest pain. And this is the common sign to see, this is the Levine sign. The aggravating factors for pain and angina, like exertion, emotion, the cold and heavy meal, very important. Pericarditis and pleuritic, swallowing and with movement or coughing or respiration to be localized pain, musculoskeletal, and aggravated with movement or not. Relieving factors, angina always relieved with rest or sublingual nitrates, esophagitis relieved with food and antiacid intake or milk, pleuritic with holding breath. Associated symptoms, it may be associated with dizziness, shortness of breath, sweating, chest pain, rapid heart rate or irregular heartbeats, and nausea. All may suggest pain of cardiac origin plus minus esophageal. The breathlessness may be seen with patient with myocardial infarction, pneumothorax, or pericardial or pulmonary embolism. Fever may be seen in patient with inflammatory condition like pericarditis or pleuritis. Dysphagia may be seen with patient with esophageal diagnosis. Paresthesias, headache, and insomnia may be seen in patient with anxiety. Pain and hematemesis may be seen in patient with esophageal problem or peptic ulcer. The pain, site of pain, and the probability. In the mid-chest, it may be heart attack, may be aortic dissection, angina, pulmonary embolism, mitral valve prolapse, spontaneous pneumothorax, acute pericarditis, pneumonia, may be esophageal pain, osteochondritis, or herpes zoster. The pain in the shoulder may be related to heart attack, angina, may be related to acute pericarditis, aortic dissection, and may be perforated meniscus. In the left arm, it may be more with heart attack and angina. In the back, it may be heart attack, aortic dissection, especially in acute aortic dissection. Starting pain in the back may be an alarming sign from acuteness, and the side may be an alarming sign to catch his diagnosis. Acute pericarditis, esophageal pain, spontaneous pneumonia or pneumonia with infection. In the abdomen may be with heart attack or perforated meniscus. The cardiac pain and the non-cardiac pain. Cardiac pain is central and diffuse, may be constricting in nature, radiating, increased with exertion and emotion, and meals, heavy meals, decreased with rest and use of sublingual nitrates, and may be associated with breathlessness. The non-cardiac pain may be peripheral and localized, may be stabbing in nature, may be present or absent, may change with posture and movement, not relieved by rest or nitrates, and maybe system related. The past history, you should ask about presence of diabetes, vasculitis, hypertension, use of steroids or oral contraceptive pills. There's previous history of prolonged bed rest or surgery, and the history of trauma. And personal history, you should know what about the diet, the habits of patients like smoking or alcoholism, and the family history, like history for coronary artery disease, especially the premature coronary artery disease, hypertension, presence of diabetes or dyslipidemia, history of collagen vascular diseases or congenital heart disease. If we have a chest pain case, we should discriminate between the pain that remarking for a non-cardiac chest pain or cardiac. If cardiac, think for one of two. Is it ischemic or non-ischemic? If ischemic, think of angina or myocardial infarction. If non-ischemic and urgent, think for myocarditis, pericarditis, or mitral valve prolapse. What about the heart score? Heart score, there is an H, which is history, given 2 if highly suspicious, 1 if moderately suspicious, 0 if slightly or non-suspicious. E is ECG, given 2 with significant ST segment depression, 1 with non-specific repolarization disturbance, and 0 if normal. A for age, 2 if age over 65, 1 if from 45 to less than 65, and 0 if less than 45. R for risk factors, presence of 3 or more risk factors or atherosclerotic disease giving 2, 1 or 2 risk factors giving 1, 0 if no risk factors known. And what about troponin? Giving 2 if 3 of upper limit of normal, 1 if 1 to 3 upper limit of normal, and 0 if lower than upper limit. Low risk is heart score to be 3 or less. And what about the 6-week MACE? If we have 7 or more points, we have the highest MACE, about 50% to be decreased if we have a score from 4 to 6 to about less than 20%. And if the score is low of 3 or not, it may be 1 to 2% maximum. If we get faced with a case of chest pain, the GP should take medical history, physical exam, and do ECG within less than 10 minutes. If in outpatient cardiology, go for chest pain if no emergency. Then to rule out or rule in, what about the chest pain nature? If in dispatch center, we take a medical history, hemodynamic is stable or not, then go for ambulance crew to take medical history and physical exam and do an ECG in less than 10 minutes. If the ECG, which is done in less than 10 minutes, shows go or direct transfer to the cath lab, or then go to emergency department, emergency room, observation unit, chest pain unit, or intensive care unit, if no STEMI, to take medical history, physical exam, and again to re-evaluate the ECG within 10 minutes, and for lab testing. If the patient hemodynamic is stable, can go for further evaluation of the chest pain nature. If the ECG show that there's a STEMI case with hemodynamic instability, you should go primary to primary PCI, maybe use of mechanical support, and put your patient in the intensive chronic care unit. To take home messages, chest pain is a common presentation to the ER. Diagnosis of the cause of chest pain is an important part for the correct management. A good history, physical exam are essential to help the diagnosis and exclude some types of chest pain. Investigations complement the history and physical examination. And thank you very much.
Thank you, Professor Tamer. Actually, I think chest pain is one of the very important presentation in the emergency room. And as you explained, chest pain may be something which is very irrelevant, something very benign, and sometimes it is very serious. So it's our role to differentiate. Actually, I have an observation about some of the diagnosis written on the paper of the patient with chest pain. Sometimes we write atypical chest pain. And many of these atypical chest pain, by definition, is really non-anginal chest pain. So we have to differentiate between non-anginal chest pain and atypical chest pain. Atypical chest pain must have two of the three criteria of the anginal pain, and not any stitching should be considered atypical angina. So differentiation between angina, non-anginal, and atypical is very important.
Yes,
Dr.
Atif, first time, according
Dr.
to the
Tamer.
point mentioned by Dr. Ashraf, what's the difference between atypical and the non-cardiac or non-ischemic chest pain? The typicality of chest pain must be related to the overall risk of patient and the susceptibility of ischemic source, maybe typical or atypical, but non-ischemic chest pain is totally different, and this prescription make a difference between the two diagnoses. It's totally different to have a chest pain probable to be ischemic, but it is atypical, and the other side is in non-ischemic chest pain, which is totally different. We may go as a patient to home safely with some prescriptions, not going for the schedule of ischemic chest pain.
Dr. Tamer, can I have a comment for you, Dr. Tamer?
Okay.
You hear me?
Yes, I hear you very well.
Okay. You know, all of us know the emergency room, how the patient is with chest pain is panic, his family or companion are panic, the crowded atmosphere in the emergency room. And okay, we have many algorithms, we have many academic charts, but what is recommended time that should be given for the differential diagnosis and taking history of chest pain at the emergency room? Because, you know, time is ticking and urgent. Because if we start to make the differential diagnosis with all this criteria and we'll take history, I think it will take more than 15 minutes or 20 minutes. Do you think there is a recommended time for such cases?
Okay, the mentioned time to be stick with is to have an ECG within 10 minutes to exclude or prove that the patient is STEMI or not. This is the first issue. The second issue, the algorithm to analyze the chest pain may take few minutes, from 5 to 10 minutes, to have an initial or probability of the chest pain. So we can do all the procedure within 10 to 15 minutes with going to a proper diagnosis of the chest pain nature, and we may have in 10 minutes the ECG, and we can decide after that which way will complete with the patient. Is it enough to go for home, or it is deserved to go for laboratory and more investigation? So it means 10 to 15 minutes.
From 10 to 15 minutes.
Yes, and should have less in ECG less than 10 minutes if we have a suspicion of STEMI or an acute coronary syndrome.
And the troponin?
Troponin is falsely used now because it is overprescribed, and if patient have a negative troponin in presence of typical ischemic chest pain, the patient probability is high and troponin is negative, ECG normal, we go patient for the home, and then coming back, can come back again with a myocardial infarction, true STEMI, like inferior and like anterior myocardial infarction. So we should depend on the history and the probability of chest pain. What is the risk profile of the patient? What is the typicality of chest pain for ischemia or non-ischemia before going to troponin and others? Troponin and other labs and other investigation may proceed with to confirm or exclude the diagnosis if we don't suspect an acute coronary syndrome. But to go back to home or prescription and go out of the ER just only by negative troponin may be a fatal mistake.
Do you advise one to take history, one doctor to take history, and one doctor to examine, and nurses to take the blood sample in a group? Not only one.
I think one doctor is enough to take the history, and we have the help from a nurse to have the ECG simultaneously during taking the history in emergency time. So the doctor can do the job within few minutes perfectly.
Okay, thank you, Tamer. Thank you. Professor Hazem? Professor Hazem?
دكتور عاطف، أنا بشكر الدكتور تامر. was very illustrative. والايشو بتاع التشيست بين ده يعني دائما خطر، نتيجه زي ما انت شفت كده differential diagnosis is يعني كميه كبيره يعني. لكن at the end I think the score system والprobability system I think this is the best way to put your patient in the category of cardiac or non-cardiac, and the risk of this patient to interfere I think is very important. المشكله اللي احنا بنواجهها يا سي مثلا عندنا في مستشفياتنا، عندنا نيرلي يعني انك انت يا اما تاجنور وتروح العيانين، يا اما تعمل اوفرلود على السيستم بتاع المستشفى وتدخل الناس كلها الكاجواليتي وتطلع بيهم المستشفى. فعشان كده في الامرجنسي ديبارتمنت يعني احنا عندنا في المستشفى في كارديولوجيست في الامرجنسي، يعني في الاي ار، يعني احنا عندنا اتليست من 7 ل 8 دكاتره في الاي ار، منهم كارديولوجيست في الاي ار بس، ما بيعملش حاجه ثانيه في الاي ار، ما بنستدعوهوش من الوورد، ما بنسوش من الكوروناري كير، تراينج تو ان الكارديولوجيست ده يقدر ينتربريتيت مع العيان اللي جاي بالتشيست بين ده، وده قلل بكتير ان احنا نفقد عيان جاي باكيوت كاردياك تشيست بين باكيوت كاردياك بروبلم. استبعدنا ان عيانين كتير قوي يدخلهم المستشفى من الخوف والقلق، ان عشان ما يقولكش في الاخر فروم يعني ميديكو ليجال بوينتس بالذات عندنا في المستشفى ان انت روحت عيان عنده تشيست بين والعيان حصل له حاجه ما روح يعني.
دكتور انا عايز اقول لحضرتك بس انه في دروباك كده موجود في ايجيبت. دكتور الاستقبال المفروض يكون الموست اكتر واحد او اشطر واحد هو موجود في الاستقبال، لان الديسيجن بتاعه هو الجيت بتاع كل البروسيس. يعني لو العيان في التايم دون lost from diagnosis، تمام، دي تو مس diagnosis من اللي موجود في الاستقبال، البيشنت كله lost او هيرجع complicated. فاحنا بنفاجئ انه الليست يعني اقل مستوى بنقابله موجود في الاستقبال، دكتور صغير، دكتور لسه مبتدئ، دكتور امتياز، and this is a great mistake. تمام، المفروض الامرجنسي اللي موجود فيها one of the most careful team، لانه هو صاحب الديسيجن الاول والاخير اذا كان العيان هيكونتينيو او هيديسكونتينيو ميديكال بروسيس. فبالتالي it is recommended to have very well qualified whatever cardiologist, emergency doctors and the care doctor, giving care doctors to be the most careful one, which can make the differential diagnosis, which is very critical, not to have for the least patients with this experience. The doctor with this experience cannot differentiate well. So I think it is recommended to have the most qualified one in the ER.
Thank you, Professor Tamer. And now, Professor Hazem Khamis, please, can you introduce the next speaker?
It's an honor يعني and a pleasure to invite our يعني brother. طبعا هو صغير عننا بكتير بس هنعمل ايه يعني. احد نجوم القلب يعني دكتور احمد بنداري، مدرس القلب في جامعه بنها. احنا لا نثني كتير على الدكتور بنداري، بس مستنيين نشوف الايكو بيعمل ايه في الاي ار، وما يكونش بقى عيان مثلا عنده كاروتيد دايسكشن. يعني بقول لك يعني خلينا في
Thank you, Professor Hazem, for this nice and humble introduction. And thanks for my second family, the IAVA, for inviting me to be with you in this great night, discussing critical topics for the healthcare management of our patients. Can you hear me well at first?
Yes.
And the slides are clear?
Yes, everything is okay, Ahmed. Cool.
Okay, let's go on. Taking the point from my dear elder brother, Professor Tamer, who discussed how could we assess properly the chest pain in the emergency department. This presentation is discussing one of the investigations which are built upon the shoulders of good history taking. This is the echocardiography in the emergency department. And within the next few minutes, we will discuss how could this investigation be a very versatile and beautiful tool to diagnose acute medical conditions, and I will present them in a case-based scenarios in order to be very educational. First, going back in time to those old days, 20 or 25 years ago, where the echocardiographic machines were very bulky, occupying almost the quarter, and sometimes in the initial days, half of the room. They were impossible to be transferred from room to room. But now we have echocardiographic machines that can be as small as you can see. Smaller or larger, you have now a very portable echocardiographic machines that could be transferred easily from the emergency department to another room and vice versa in order to diagnose critical conditions anywhere and anytime. Our first case today is a 69 years old male who had long-standing hypertension and is brought to the ER by his relatives after he complained of severe chest pain followed by syncope and right upper limb monoparesis 3 hours before. Clinically, his conscience is cloudy, the blood pressure is 80/60, the heart rate is 120 and regular. The cardiac examination was unremarkable, but a rapid neurological review showed a right upper limb acute flaccid weakness, and the ECG showed sinus tachycardia. As you can imagine, or as you can take from this case, you should put aortic dissection into your priority or in the top differential diagnostic considerations in this patient, because this patient is an old age male, long-standing hypertension, in addition to the rapid onset of severe chest pain, which is followed by a neurological deficit. As you can see, the examination is unremarkable and the ECG did not show anything. If we went back to the basic science, see how can we confirm the diagnosis of a suspected acute aortic dissection, we have in the play 4 imaging modalities. The first, and is the most widely recommended across the board and in the guidelines, is the CT autography with contrast. However, this machine and this lab is not available in all places, especially in low and middle income countries. And sometimes you have the CT lab occupied by a case that could take time. So, in this case of suspected acute aortic dissection, time equals life. You need time to diagnose this case of suspected acute ascending aortic dissection, which is sometimes called type A aortic dissection. You know that this diagnosis is, if confirmed, is a dismal one that carries more than 50% mortality in the first day without a prompt surgical intervention. In this case, transthoracic echo could provide a very rapid, ready-to-use tool to diagnose this case, as we will see now, but we should be always reminded that we have other tools, such as transesophageal echo, but it's employed intraoperatively, and the MRI, but as you know, it's time-consuming and is expensive and is not readily available in all places. You can see this video, the transthoracic echo, which was done emergently in the ER, showed a flap in the ascending aorta together with the dilated ascending aorta, which points to a very, very high possibility of type A aortic dissection. And this shows us how echocardiography could provide a high probability of such a life-threatening diagnosis in order to save time for the patient, to save time for the system, and to save life in the first place. Our second case is a 29-year-old female with a free past medical history. She is presenting to the ER with acute onset of dyspnea 12 hours ago. Of note, she is on oral contraceptives for 4 years. Clinically, she is dizzy and sweaty. Blood pressure is 70/40. The heart rate is 135 and regular. Cardiac examination again was unremarkable, and the ECG showed sinus tachycardia. I know that this is a common presentation, but in any young to middle-aged female patient presenting with acute onset of dyspnea, and she is on oral contraceptive pills, pulmonary embolism looms. Pulmonary embolism should be considered among the first 2 or 3 differential diagnoses in this patient. If we go to the European guidelines for management of pulmonary embolism that was published in 2019, and if we look to the algorithm of how to deal with a suspected pulmonary embolism in a patient like our patient with hemodynamic instability, we will find that the guidelines put forth a high priority for doing a bedside emergent transthoracic echo. And this is the main value of echocardiography in diagnosis of pulmonary embolism that's associated with hemodynamic instability. To cut the story short, in patients with suspected pulmonary embolism who is presenting hemodynamically unstable, if you did a bedside transthoracic echo and you did not find an RV dysfunction, sit down for this. You can safely exclude pulmonary embolism and you can search for other causes for shock or instability. And this is big. On the other hand, in patients with suspected pulmonary embolism and hemodynamic instability, and if you did a bedside transthoracic echo and found an RV dysfunction, you can or you are allowed, in other words, to start treatment for this patient as being a high-risk pulmonary embolism while arrangements are being made to do CT pulmonary angiography if it is not immediately available. In this patient, as you can see, the yellow arrow is pointing to a hypocontractile free wall of the right ventricle, which is, as you can note, dilated right ventricle. At the same time, the blue arrow is pointing to a preserved contractility of the apex. So, to conclude what we are seeing in front of us now, we are seeing a dilated RV, a hypocontractile RV lateral free wall, and a preserved contractility of the RV apex. This sign is a very famous and renowned sign in echocardiography in patients with acute massive pulmonary embolism associated with RV dysfunction, which is called the McConnell sign. This patient's life was saved by giving her the accelerated regimen of streptokinase. Our third case today, and actually it's a funny case in which you can be easily involved with your surgeon colleague in the ER. But how come? Let's look. This is a 19-year-old male with pre-past medical history who is brought by police to the ER after a major struggle in which he received a stab wound in the chest, after which shortly he collapsed. Clinically, he is gasping and sweaty. The blood pressure is 90/60. The heart rate is 100 beats per minute and regular. The chest examination showed an open wound, which is 2 centimeters long in the left parasternal area, and the neck veins are congested. Of course, in any patients receiving what we call a penetrating chest trauma associated with dynamic instability and congested neck veins, as you can see, 2 main differential diagnoses are on the horizon. Number 1 is tension pneumothorax, but it can be rapidly excluded by finding a diminished air entry using your simple stethoscope in addition to a simple chest X-ray. And the other differential diagnosis is a pericardial collection of blood or fluid leading to what we call tamponade physiology. And actually, this was the case in this patient. As you can see, the emergency echocardiographic evaluation in this patient, which was done in the surgical ward, revealed a pericardial effusion, and a very characteristic sign called the right ventricular diastolic collapse, which points to a tamponade physiology. This patient's life was saved by doing a prompt surgical intervention, and suffice to know that any delay in performing ER echocardiography could have costed this patient his life. I'd like to draw your attention to this very nice paper. It's an old one published in 1992 in the Annals of Emergency Medicine, but it's a very nice one. In this paper, the investigators compared those patients who have underwent emergency department echocardiography in penetrating chest trauma to those patients who did not had an echocardiography. And sit down for this, the survival for those patients suffering penetrating chest trauma was 100% when performing echocardiography. Yes, I said it correctly, 100%. No single patient died. And the survival in those patients who did not do echocardiography was just 57%. And this beautifully illustrates the importance of a ready echocardiographic machine in any patient presenting with thoracoabdominal traumas, especially penetrating ones. The last case today actually is a very peculiar, uncommon, but mysterious case. It's a 35-year-old female with free pass medical history who was brought to the ER by her husband after she was witnessed to collapse in the street just 5 minutes ago. Her husband gave a history that she had a severe diarrhea the day before. Clinically, the patient was found to be in cardiac arrest, but with this rhythm. All of us know when we have cardiac arrest and at the same time we have what we call an organized electrical activity. This is called the pulseless electrical activity, which is abbreviated PEA. Anyway, CPR efforts were started immediately for this patient. The husband shouted, "Oh, please, doctor, do anything. Her younger brother died suddenly, the same pattern 1 year ago." And we here have the clues. 3 main clues in this case prompt the evaluation of her by emergency echocardiography. The first is the presence of diarrhea or volume loss. The history in this patient started the day before. It didn't start by the cardiac arrest. It started by the acute severe diarrhea 24 hours ago, which was followed by pulseless electrical activity. And from the basic medical school, we have been taught that any patient who is presenting arrested with pulseless electrical activity, that rhythm or that arrest rhythm points to a potentially treatable cause if discovered. Finally, the husband of this arrested patient indirectly gave you a clue that there is a family history of sudden cardiac death. All the 3 clues prompt evaluation of the patient by echocardiography while CPR efforts are being performed. And we had the surprise. This patient suffered from acute severe hypovolemia from the diarrhea, which came on top of a severe form of hypertrophic cardiomyopathy, leading to what we call dynamic left ventricular outflow tract severe obstruction. Of course, aggressive IV fluid have been started immediately, and the return of spontaneous circulation was obtained in a few minutes. The patient was discharged alive the next day with an appointment to counsel her regarding her future management of hypertrophic cardiomyopathy. This illustrates the beautiful role of echocardiography in evaluation of patients with cardiac arrest. Can you imagine this? You can use your echocardiographic machine in the ER to evaluate the patients presenting with cardiac arrest, provided that they are presenting with that rhythm, pulseless electrical activity. And always remember that this rhythm sometimes points to a potential treatable cause that could reverse the whole scenario. Summary of this lecture for the sake of time is that we have primary and secondary indications for echocardiography in the emergency department. The primary indications, and I'd like you all to keep them by heart, are number 1, suspicion of precardial effusion. Number 2, the presence of pulseless electrical activity, as we have seen the female patient. Number 3, the presence of otherwise unexplained hypotension. And finally, thoracoabdominal trauma, especially penetrating ones. The secondary indications, which are less important, are acute cardiac ischemia and the guidance of pericardiocentesis if it deemed necessary. I'm grateful that you listened. Thank you. This was me, Ahmed Bindari, signing off, and goodbye.
Thank you, Ahmed. Thank you very much for this beautiful presentation.
Thank you,
I
sir.
think number 1, إن قصة الإيكو دي is very very important in the ER. Number 2, إن إحنا لازم يبقى عندنا السكيلد بيرسونيل اللي هم كان diagnosed by the echo. لذلك أنا كنت بستغرب في المستشفيات and in the university hospital in the cardiology department بعض الكارديولوجيات بيتأخروا في تعليم الجونيورز النيو ستاف جونيورز الإيكو، يقول لك ده مرحلة إيه متأخرة، خليك في الكلينيكال، خليك في، وينزلوا ياخد نبطشيات. فأنا أقول لكم التجربة دي لأن أنا لما رحت المعادي زمان وأنا نايب يعني in few weeks كنت بتعلم الإمرجنسي إيكو، يعني هم مش عايزين نبقى إكسبرت في الإيكو but at least كان ساعتها التامبونات، كان ساعتها البريكارديال إفيوجن هو المين تاسك للإيكو بتاعنا، لأن التامبونات سبوت دايجنوزس باي ذا إيكو، تحط البروب على العيان هتعرف إن ده. فأعتقد إن المسج إن إحنا لازم نبقى بدري معلمين our junior staff how to do the echo. Any comment or question from our colleague?
أنا بأيد supporting Professor Hazem observation. At least junior residents لازم يبقى trained well على ال emergency echo findings at the start. I don't want him to accurately assess the mitral regurg or the pulmonary hypertension. This could be done by expert echo man. But however, in the emergency room, it's very important to have one who are well trained on some findings that are important in the emergency room.
أحمد شكرا على المحاضرة الجميلة والكيسز الجميلة.
Thank you.
أحمد, what is the main target for ER doctor to go with data with bedside echo?
Yes.
هيتارجت إيه في الأول as the priorities to look for؟
طيب الحقيقة ال ER doctor علشان يعمل echo at first he should be specialized. This is number 1. Number 2, he should be trained the fact that if it is not seen, it will not be diagnosed. علشان كده احنا دايما بنقول لهم الفور major critical conditions اللي هم aortic dissection والبريكارديال tamponade وكذلك في حالات البالسلس electrical activity ان هو ياخد باله من الميجور structures. رقم 1 the pericardium. رقم 2 and it's easy to be brought by echo ascending aorta or aortic valve to look for a flap. Number 3 and this is very important any major structural abnormalities. احنا بنقول لهم دايما look for the major structures, look for the pericardium, look for the aorta and then correlate this with the patient history. احنا كنا دايما لما بيكون مثلا سينيورز ومعانا جونيورز ويقابلنا حاله زي دي في الاستقبال which is not common كنت اجيب وات ايفر هو كان موجود فين واوريها له، لان هو لو ما شافهاش ممكن بعد كده تعدي عليه بسهوله قوي حتى لو بص بالايكو وقال خلاص ما فيش حاجه، لكن هو ما شافهاش. if it is not seen before it will miss. فمعرفش راي حضرتك ايه. انا شايف ان دي هي البيسك كونسبتس اللي لازم اي جونيور كارديولوجيست ياخدها من his senior in the emergency department regarding use of echocardiography.
احمد برضه معلش هي الموست critical indicators or signs of echocardiography to have a differential diagnosis of an acute chest pain, like we have an acute pulmonary embolism, what's the value, and so the most critical points to get with the bedside echo in ER.
Yes. يعني انا مش عارف هل حضرتك مثلا سؤال حضرتك خاص في البالمونري امبوليزم تحديدا
لا
ولا
انا بقول از بالمونري امبوليزم، ايه هي الموست كريتيكال ساينس اللي ممكن يجيبها الدكتور الاي ار بالايكو
تمام
هتهلب تو ديفرنشال دايجنوز في الميجور كيسز اوف تشست بين.
The main value of echo في حالات ال suspected pulmonary embolism بتيجي لو كان ال patient presented with hemodynamic instability. الفاليو الجميلة إن with use of echo in patients with suspected pulmonary embolism and hemodynamic instability لو لقينا right ventricle is not dilated and is not dysfunctional مفيش hypokinesis زي اللي أنا عرضتها you can safely exclude the presence of massive pulmonary embolism and you are prompt to search for other causes for this shock or instability. دي مهمه جدا. فاحنا نقدر نقول ان هو ده very good negative test في حالات البالمونري امبوليزم اللي بتيجي بهيمودايناميك instability, but at the same time it does not prove that this case is not pulmonary embolism if the patient is hemodynamically stable. يعني لو البيشنت الفيميل اللي انا عرضتها دي كانت جايه ضغطها 110/70 جاست بس ساينس تاكيكارديا 110, استخدام الايكو كارديوجرافي هنا مش هيبقى of great value. You need to go further by doing D-dimer, CT pulmonary angiography even if it will be delayed and so on. فبنركز على ان فايده الايكو في حالات البالمونري امبوليزم بتيجي مع وجود الهيمودايناميك انستابيليتي لان هو could safely exclude this diagnosis if the RV is not dilated.
دكتور احمد لو سمحت a very يعني critical question.
اتفضلي.
How many echoes placed in our ER in Egypt؟ يعني هل كل الامرجنسي رومز اللي موجوده في مصر فيها ايكو؟ عشان بس الكلام بيبقى يعني
كلام سليم.
ماشي سليم. لان انا مثلا كنت شغال في مستشفى الايكو كان فوق في العنايه، ما كانش تحت.
يس وبيتقفل عليه بالمفتاح ساعات.
والمفتاح مع فلانه او فلان
مع الممرضه وروحت.
انا عايز
الحقيقه لحد وقت قريب علشان ابقى امين فعلا يا دكتور عاطف ما كانش عندنا ريدي ايكو كارديوجرافيك ماشين نير باي لاي امرجنسي ديبارتمنت الا المستشفيات اللي بنقول عليها تيرشري كير سنترز في مصر علشان ابقى امين. ولكن النولج اللي احنا بنتكلم فيها النهارده في اخر 5 سنين او على الاقل 8 سنين بدات تتغير، وخاصه مع وجود الايكو كارديوجرافيك ماشينز اللي ممكن تكون حجمها بحجم زي طفل صغير او تتشال في شنطه موجوده عندنا دلوقتي. عندنا مثلا هتكلم على المستشفى اللي انا شغال فيها، احنا عندنا تقريبا بورتابل ايكو حجمه ما يجيش يمكن 60 في 40 وزنه حوالي 3 أو 4 كيلو، بنقدر ناخده الاستقبال لاي حاله حتى مش هتقدر تتحرك. فزمان ممكن يكون فعلا كلام حضرتك كان فعلا صحيح، ما كانش موجود الكلام ده خالص، ولكن اللي انا بلمسه اتليست ات ماي هوسبيتال لا في اخر 5 سنين احنا ممكن نعمل تقريبا كل يومين ايكو كارديوجرافي في الاستقبال طوارئ العيان suspected acute cardiac condition.
Thank you very much, Professor Ahmed, for your.
Thank you.
Excellent. And now I have the pleasure to introduce my dear friend, Professor Dr. Ashraf Rida, Professor of Cardiology and President of IAVA, in a very important topic, which is a daily occurring in the emergency rooms, the hypertensive emergencies and urgencies. And we should listen carefully because I think we have many mistakes are done in the emergency room when we differentiate between emergency and the urgency. So Professor Ashraf, please proceed.
Thank you, Professor Atif. And as you said, actually, the presence of a person in the emergency room with a high blood pressure is an important issue. Whether we send him home or whether we admit him to the intensive care, should we rapidly decrease this elevated blood pressure, or should we be patient and wait and see and just observe and maybe give some oral meds? So it is very important to differentiate between some elevation of blood pressures, between urgencies and emergencies. This is an example of a 59 years old man presented to the ER with episodic headache that resolved spontaneously. In the last week, the headaches have become much more frequent, occurring almost daily, and are accompanied by dizziness and palpitation. Actually, on arrival to the hospital, the patient is still complaining of severe persistent headache. His blood pressure is above 230 over 135. The heart rate is 90 per minute. He's sweating, complaining of dizziness, blurred vision, and chest pain. So, should we admit this patient to the intensive care? Should we start immediate blood pressure lowering? What is the probable diagnosis? If this is a hypertension urgency or hypertension emergency, because there is big difference between dealing with each situation. So the first question is it a hypertensive urgency? Is it a hypertensive emergency? Is it just a grade 2 non-urgent case of hypertension? Or it may be it's hypertension with unstable angina, because there is chest pain and palpitation and sweating. Of course, you need to take some history, some investigations, and maybe a good physical examinations. And one of them, which is very important, is to measure the blood pressure accurately using a proper cuff size in the proper situations and take many measurements to be sure that this is the real blood pressure. So what is the difference between hypertensive urgency and hypertensive emergency? The difference is not in the level of the blood pressure rise, because in both situations, the systolic blood pressure is above 180, diastolic or the diastolic above 120. However, emergency cases of hypertension means that there must be evidence of target organ damage, which are not present in hypertensive urgency, and it makes the whole difference in the managing of the patients. You should look at the target organ damage in the brain, like hypertensive encephalopathy, edema, intracranial hemorrhage, stroke. Look at the retina, fundus examinations, papilledema. Look at the cardiovascular system and rule out acute coronary syndrome, acute pulmonary edema, congestive heart failure, aortic dissections. Any of these findings put the patients from the category of urgency to category of emergency. And additionally, the situation of the kidney and nephritic syndrome or accelerated nephrosclerosis, other situations that put the patient in the emergency situation is happened during eclampsia, like the HELP syndrome or the eclampsia or the angiopathic hemolytic anemias. Regarding this patient and headache, I don't want to leave an impression that headache is an important sign of hypertension. And if we ask you a question about what is the most common complaint in hypertensive patient, it is neurologic deficit, gross hematuria, chest pain, headache, epistaxis. I won't tell you that the most common complaint in hypertensive patient is definitely it's not headache. This is a clinical research work done by Dampagulayon in 1996 from more than 14,000 emergency room visit in 1 year period of hypertensive patient. 108 made the definition of hypertensive emergency. And this is the frequency of signs and symptoms. Nearly 1/3 of the patient, or 1/4 chest pain, quarter dyspnea, and quarter neurologic deficit. And interestingly, headache was only present in 3%. Epistaxis was present in 0% in this study. Epistaxis sometimes happen with severe hypertension, but it is not most common findings. Of course, when you found this severe rise of hypertension, you should exclude secondary causes. What is the primary reason for hypertensive emergency in the world today? It is one of the secondary causes of hypertension, like renovascular disease, pheochromocytoma, hyperaldosteronism. or it is just the non-adherence to antihypertensive medication. Of course, there is a secondary causes are important, but they are rare. And the most common cause of hypertensive emergency in the emergency room is non-adherence to the antihypertensive medications. This is an example to what I said, hypertensive emergency or urgency. The untreated or suboptimally treated essential hypertension is the most common reason. Of course, other causes of secondary hypertension are there, like renal parenchymal disease, renal vascular disease like renal artery stenosis, pregnancy-induced hypertension, preeclampsia and eclampsia, or endocrinal causes like fucuromycetoma and Cushing syndrome. Important causes of the secondary hypertension are the Crohn's disease, characterized by low potassium level, the fucuromycetoma, characterized by episodic rise in blood pressure with perspiration, palpitation, and pain. Renal artery stenosis, you can find renal bruit on the abdomen by the stethoscope. Of course, Purkinje syndrome is easy to diagnose with marked obesity, short neck, or daytime somnolence and apnea attacks. Pregnancy, like HELLP syndrome and eclampsia. So it's very important to look at the circumstances, clinical circumstances, clinical history, history taking, risk assessment of your patients to see whether there is an obvious cause of this precipitating factor present or not. If you look at the clinical findings in the case of severe hypertension, it is very important to look at two things. Look at the predisposing factors and look at the sign of complications. Predisposing factors like thyrotoxicosis, hypothyroidism, hyperparathyroidism with elevated calcium levels, psychosis and constipation, for example, Cushingoid feature as a sign of Cushing disease, and look clinically at the sign of complications. Complication means target organ damage, and target organ damage is the one that differentiates urgency from emergency. Brain, headache, nausea, vomiting, delirium, seizures, coma. This is signs that there is brain affection. Retina, of course, all the grades of retinal changes with chronic hypertension, additions of the presence of papillary edema are the signs of hypertensive emergency. This is very important. The cardiovascular system is one of the most important systems that is targeted to damage from severe hypertension and manifested in the form of chest pain, acute coronary syndrome, or congestive heart failure and pulmonary edema. Of course, the kidney, active sediment in the urine, proteinuria, and the hematuria, tubular casts. This is an example of the fundal examinations and see the pulmonary edema, papillary edema. You can find, of course, many signs of chronic hypertension, like, for example, blood vessel attenuation, like flame hemorrhage, but these characteristic signs in the presence of papillary edema that is characterizing hypertensive emergency. You may find an ECG with left ventricular voltage criteria and the strain pattern as you see in this ECG with the lateral depressed ST segment. You may find in the chest X-ray some cardiomegaly and increased pulmonary vascular markings as a sign of chronic hypertension. Sometimes when expected in the presence of bruit or later on in the course of hospitalization, you may need to do CT angiogram to see whether there is renal artery stenosis or not if suspected secondary cause of hypertension. So it is very important to know that hypertensive emergency is characterized by the presence of target or evidences of target organ damages, CNS, kidney, aortic dissection, heart, congestive heart failure, and angina. So you should look clinically during your evaluation of the patient at any sign of these complications. When you ask me about the pathophysiology of hypertensive emergency, I will tell you that it's all around one statement, which is autoregulation. Autoregulation is a hemodynamic characteristics that protect many of our organ against rise of blood pressures. Autoregulation failure lead to a defective mechanism and failure of vasoconstriction in response to the rise in blood pressures. Failure of these vasoconstrictions will lead to endothelial damage, and as you see in this diagram, endothelial damage may lead to fibrinogen in the vessel wall, inflammation, and fibrinoid necrosis. So remember this word, autoregulation, and autoregulation failure is very important, whether in the kidney, whether in the peripheral vessels, even in the CNS, as we will see in a minute. What about the CNS, central nervous system, in hypertensive emergency? CNS is affected as elevated blood pressure will overwhelms the normal cerebral autoregulation. You know, the cerebral circulation is dependent on a constant flow, whatever the changes in the blood pressure. So if blood pressure rise in the brain, the autoregulation system will try to maintain a constant flow by vasodilatation. And if the blood pressure lowered, this autoregulation in the brain will vasoconstrict to maintain normal blood flow, because the brain is very sensitive to changes in the flow. So you need constant flow all the time, regardless of the variation of the blood pressure. Sometimes the acute rise and rapid rise of blood pressure overwhelm this autoregulation system and lead to vasodilatation, failure of vasoconstrictions, and leakage. And this is the mechanism or the pathophysiology of hypertensive encephalopathy, also autoregulation failure in the brain. This is an example of a nice illustration of the autoregulation in the brain. Usually, the flow of the brain is constant between mean blood pressure of 60 to 120. So during these changes of blood pressures, vasoconstriction and vasodilatation as a part of the autoregulation help constant flow throughout these mean blood pressure. However, if the blood pressure is rapidly rise to above these mean values, there is cerebral hyperperfusion and failure of autoregulation. There is difference in the treatment, whether you have urgency or emergency. Urgency, no target organ damage. And take care that in this situation, even if the blood pressure is 200, rapid reduction in the blood pressure in the presence of urgency situation, not emergency, may be associated with significant morbidity, organ hypoperfusion, ischemia, and infarction. And you need usually to lower the blood pressure gradually over 24 to 48 hours. Even you can just give some oral long-acting medications. No need for any sublingual tablet or intravenous drugs, so long there is no target organ damage. And this is very important. And I don't know, despite these CME activities by us and by other societies and other groups and universities and locally and internationally, still any patients going to the emergency room with high blood pressure is given something sublingual, whether it is Capoten. Thanks God it is not Adalat now, but it is Capoten or intravenous Lasix, I don't know why, which is maybe hazardous, as I told you, I will show you in a minute. So urgency, no target organ damage, and no urgency in blood pressure reduction. Take your time over a day or two, even with some oral medication, so long that there is no target organ damage. The situation is different if you have aortic dissection, if you have acute pulmonary edema, and I will show you the situation where you need to some rapid reduction in the blood pressure, but not in the urgency. In hypertensive emergency, when there is target organ damage, you need to reduce the blood pressure also gradually, but not over 48 hours. You have to reduce the blood pressure by 10 to 15%, or to reach the mean of 110 over half an hour to an hour. Except in a case of aortic dissection, for example, you should, in aortic dissection, rapidly lower the blood pressure over 4 to 5 minutes. Systolic blood pressure should reach less than 120, and the mean arterial pressure less than 8. So you have to know what is the situation in which you have to rapidly lower the blood pressure, and what are the situations in which you want to gradually lowering your blood pressure. So when to do rapid blood pressure reduction? Acute myocardial ischemia, for example, intravenous nitroglycerin, beta blocker, ACE inhibitor. Congestive heart failure with pulmonary edema. This situation need rapid blood pressure reduction. Acute aortic dissection, intravenous nitroprusides, blood beta blocker. Hypertensive encephalopathy. There is high blood pressure that overwhelm the autoregulation and lead to leakage in the brain. So you need to rapidly reduce the blood pressure, or subarachnoid hemorrhage. Nitroprusside, labetalol can help here. Are there any conditions where you would choose not to lower the blood pressure? Yes, especially when you have CVA with high blood pressure. Whether this CVA is ischemic or hemorrhagic. Unless the blood pressure is over 220 systolic or over 120 diastolic, you should not interfere if you have acute CVA. The exception is if you plan to do thrombolysis. Thrombolysis is not allowed above 185 systolic and above 110 diastolic. You have to reduce the blood pressure to this number if you are going to do thrombolysis. Even with hemorrhagic CVA, in which the decreasing the blood pressure may be associated with some reduction of the hematoma size, but even in this situation, we have no evidence that this is help the patients or improve the prognosis. And even in this situation, you need only to lower the mean arterial pressure 15% or less over 24 hours. What are the agents used in hypertensive emergency? A lot of agents. You want a drug that is short-acting, like the nitroprusside, which is duration of action 1 or 2 minutes. Labetalol, 3 to 6 hours. Nitroglycerin, 1 to 3 minutes. Nicardipine, calcium antagonist, 15 to 30 minutes. Ismolol, short-acting beta blocker, 20 to 30 minutes. Phentolamine, alpha blocker. These all are examples of drugs that are used in the emergency if you wanted to use an intravenous drug. And again, these are used in a situation like hypertensive emergency, with target organ damage, not hypertensive urgency without target organ damage. So the take-home message is here: hypertensive emergency is a serious event that should be diagnosed and managed accurately. The factor of time is of utmost importance in this case. Intravenous options are several and should be tailored according to the case. Investigating the cause of hypertension and target organ damage is very important to differentiate between hypertensive urgency and hypertensive emergency. Chronic hypertensive patient drugs have certain characteristics to be optimal, not just blood pressure control. And it's very important to know that the most common cause of hypertensive emergency is inadequate treatment of chronic hypertension or non-adherence of the treatment. Thank you.
Thank you very much, Professor Dr. Ashraf, for this clear message in this important matter of hypertensive emergency and urgency. As you said, headache is about 3% or 1 or 2%. All the emergency rooms in all the hospitals in Egypt, they are crowded by patients with headache, adjust the measurement in a rapid way, and then aggressive management by the sublingual tablets and the Blazix intravenous, and no assurance for the patient, no quietness for the patient. There is a panic from the headache. We should have a restrict regulation and laws that control the urgencies of hypertension in the emergency room. And for the emergency, there is something very important, and your message was clear, not to reduce the blood pressure rapidly in emergency because it will make a catastrophe. It's clear, and no question from me or to you, because we have many discussions in this matter time after time. What's your point in the strict regulation that should be laid in the hospitals of the Ministry of Health and the university hospitals to reduce the aggressiveness of the management of the urgency we see?
Really, Atif, I don't know, because even in the university, we tried our best to. I don't know what are the reasons. When they found a patient with 180, they give him something sublingual. Maybe they, because of overcrowding in the emergency, and they have no time to assess for target organ damage. I don't know. Actually, this is very bad medical behavior to give patients something which can lead to infarction or ischemia. Even the patient with hypertensive CVA, yes, you should touch this patient even if the blood pressure is 190. And I'm always saying that the lucky persons with stroke, whenever there is no near hospital for fibrinolysis, it is better not to go to the hospital, because if he went to the hospital with 190 and one shot of Lasix or one sublingual Capoten can increase the brain infarct size, and the patient, instead of having some hemiparesis, he will tend into frank hemiplegia. So it's a shame that we cannot change this bad behavioral or bad maneuvers in the emergency room, giving sublingual Capoten or intravenous Lasix to the patients.
Do you think, Professor Ashraf, that if we teach the young generations for the ophthalmoscope use, because our generation used this ophthalmoscope in the past in the emergency room, when we look to the retina of the patients, we can place an ophthalmologist who is trained to read the retina in the emergency room, and a cardiologist to rapidly evaluate this patient, plus a chemist to see if there is elevation of serum creatinine or GFR. Do you think this is it must not be controlled by one, as we see, because the cases are increasing and there's no way for our lectures or our presentations or our exam or our I come back again to the question: we should have a restrict rule. We should consider the triage, the emergencies to the ICU and the urgency to the house. We should make these patients quiet. We should assure them in the beginning. We should be quiet, because the crowdedness and the panic and the relatives around the patients are very disastrous.
Yeah, and I agree with you. And I think the message we wanted to deliver is, first of all, we have to know what are the situations that need rapid reduction of the blood pressure, yes, like acute aortic dissections, like pulmonary edema, like hypertensive encephalopathy. And we, yes, should teach and do many CME activities, how to diagnose this situation that need rapid reduction of blood pressure. In the absence of these situations, you either will give some oral medication and send the patient home if there is no target organ damage, or you need to reduce the blood pressure over 1 hour by 15%. So there is no rule of these rapid maneuvers except in situations I just mentioned. We should learn to these young generations.
Okay.
Can I have a comment? Yeah, thank you so much,
sure.
Professor Ashraf, for such a lovely lecture. And something very important that you said is that non-adherence to medication is very important. And this is why also the ESC and all the guidelines suggest and start combination therapy, triple therapy. And this is very important to have a single pill with 2 medications, 3 medications. And by chance, we have Novartis here, our sponsors. So they have one of the biggest portfolios for combination and triple therapies. Please control your patient's blood pressure. Very important point, Professor Ashraf. Thank you so much.
This is very important because all the studies show that the most common cause of hypertensive emergency, the primary cause that lead the chronic hypertensive patient to go to the emergency room with complications, with hypertensive emergency, is non-compliant, non-adherent, suboptimal treatment. And many of them, because they have 3 to 4 tablets per day for hypertension, sometimes they forget half the meds. So it is very important to have this one pill policy that contain 3 drugs, especially in cases of chronic hypertension in high-risk populations that need many drugs, rather than giving them 3 or 4 drugs per day.
Thank you, Professor Ashraf, and I give the platform to my dear friend, Professor Ahmed Shawqi.
Professor Atif, Professor Ashraf, thank you so much. I would like to thank the IAVA board. A big thanks to ICOM, Mariana, and the whole team. Thank you so much, Novartis, for this non-promotional event and your continuous support for us. The ER, it's an important place. It's an important place where patients might die if they are not diagnosed correctly, if the patients are not treated appropriately. We've seen today how chest pain is very important. Chest pain is not just myocardial infarction. Chest pain can be other causes. We've seen how an echocardiogram, of course, there are, and tomorrow we're going to discuss the ECG in the ER, and this is going to be a very interesting part. Also, how echo can be life-saving. Professor Ahmed bin Dari's lecture was very clear. And finally, Professor Ashraf is talking about the most important risk factor. If we don't control hypertension, mortality will increase. Controlling blood pressure is the most important way of avoiding hypertensive emergencies and urgencies. And how to diagnose this and how to treat was really touched upon very brilliantly by Professor Ashraf. Thank you so much for being with us today. We're waiting for you tomorrow after Friday prayers at 2 p.m. And we will continue tomorrow with the ECGs of chest pain, the ECGs in an acute coronary syndrome, and also the management of myocardial infarction. Hope to see you tomorrow.
Thank you. Bye-bye.
Thank you.
Thank you, Ahmed. Thank you, Atif. Thank you, Tamer.
Thank you very much.
See you tomorrow, inshallah.
Inshallah.
Thank you.
Bye-bye.
Bye.